Imagine you are a neurosurgery resident in Massachusetts General Hospital, and you are just coming out of hospital fidgeting your Mercedes Benz car keys, and you just opened the car door and entered. And there, at that time, you will remember these 1 hour sessions of Step 1 USMLE First Aid. So, welcome back to Not So Complicated, and we have completed our Hematology and Oncology session 1. This is our second and final session, so we'll try to complete Hematology and Oncology in this session. Okay, let's begin. So we start from leukopenias. Okay, so what are leukopenias? Leukopenias are something that is like, this is a condition in which the leukocytes are in decreased amount than they usually used to be. So leukopenias, there are different types of leukocytes like neutrophils, and then lymphocytes, and then eosinophils. So basically, if there are these decreased amount of neutrophils, that is also called neutropenia, and the absolute neutrophil count is less than 1500 cells per mm cube. In severe infection cases, typical when less than 500 cells per mm cube. So neutrophils are actually, these are defensive cells, these are immune response cells, right? So if these cells are decreased in amount, so obviously it is a very prone condition for infection to develop. So the causes of neutropenia can be sepsis or post-infection, and drugs including chemotherapy, aplastic anemia, autoimmunity like systemic lupus erythematosus, and radiation, and also congenital diseases, right? And the lymphopenia is another type of the lymphopenia or lymphocytes are another type of leukocytes. So basically, lymphopenia occurs if the absolute lymphocyte count is less than 1500 cells per mm cube again. And in children, the criteria is slightly higher, because in children they are basically already increased in amount, right? So in 3000, less than 3000 per mm cube in children is the criteria for lymphopenia. And that this occurs usually in HIV or Dejar syndrome, and SCID is severe combined immunodeficiency, and SLE is systemic lupus erythematosus, glucocorticoids, radiation, sepsis, postoperative cases. In eosinophils, the absolute eosinophil count should be less than 30 cells per mm cube, because their normal range is already in lower count. So this occurs in Cushing syndrome and also in glucocorticoids. So glucocorticoids cause neutrophilia despite causing eosinopenia and lymphopenia. This is a very high yield point right here. You have to remember this, right? So glucocorticoids cause neutrophilia, which is increased in neutrophil amount, but the other two types of leukocytes like eosinopenia and also lymphopenia occur. So why? Because glucocorticoids decrease activation of neutrophil adhesion molecules, impairing migration out of the vasculature to the sites of inflammation. So we have studied about inflammation in our general principles again, and if you haven't watched that video, I'll be attaching this in the I portion above. So in contrast, glucocorticoids sequester in eosinophils in lymph nodes and cause apoptosis of the lymphocytes. This is why there is increase in there is increase in neutrophil count, but also decrease in eosinophils and lymphocytes. You have to know this. So let's go to the hem synthesis. Hem is a protein part of hemoglobin, non-protein part of the hemoglobin, and hem synthesis occurs in very large amount of steps, and there are a large number of enzymes that are used in the hem synthesis, and any abnormalities caused by those enzymes are called porphyrias. So we will be talking about porphyria, right? So these porphyrias are usually hereditary or acquired conditions of defective hem synthesis that lead to accumulation of hem precursors, because since the enzymes are not being able to produce the intermediate products, then the like forwarded intermediate products, then preceding intermediate products will accumulate, right? So these are hem precursors that will get accumulated. So lead inhibits specific enzymes needed in hem synthesis. So lead poisoning is also a very common condition that we have to consider and study, because this is very largely asked in USMLE Step 1. So in lead poisoning, what actually happens is the ferrosolidase and ALA dehydrogenase enzyme is affected. So ferrosolidase is the enzyme required in the last step of hem synthesis. So the accumulation occurs in the protoporphyrin accumulation occurs, because these protoporphyrin are then turned to the hem protein by ferrosolitase enzyme, right? So that is why there is accumulation of protoporphyrin, and also ALA in blood is increased. So the presenting symptoms are microcytic anemia, that is basophilic stippling of peripheral smear. Basophilic stippling occurs. Figure A. Here you can see this is basophilic stippling. And then ringed sideroblasts in bone marrow are seen, and also GI and kidney disease can occur. So acute intermittent porphyria, it is usually due to porphobilinogen deaminase enzyme deficiency or affected enzyme. So porphobilinogen is an intermediate product, and that should be deaminase to form the other product, right? But since the deaminase enzyme is defective, the porphobilinogen gets accumulated, and also ALA is accumulated. The symptoms are 5 Ps in acute intermittent porphyria. This is very important. You have to remember this. Acute intermittent porphyria is very important thing. So remember, the symptoms are 5 things, 5 Ps. So P for painful abdomen, P for port wine colored P, and then P is urine, obviously, and then polyneuropathy, psychological disturbances precipitated by factors that increase ALA synthesis, like drugs, that is CYP, again 450 inducers, and alcohol, and also starvation. The treatment is hemine and glucose. So another one is porphyria cutanea tara, that is PCT, right? Porphyria cutanea tara, and the affected enzyme right here is decarboxylase, uroporphyrinogen decarboxylase. So basically uroporphyrin is the accumulated substance that causes tea colored urine, and blistering cutaneous photosensitivity and hyperpigmentation is seen. As you can see in this figure, there is hyperpigmentation and also blistering, like bone kind of blisters, right? So the most common porphyria is porphyria cutanea tara. This is the most common porphyria. You have to remember this. You can note it down. Most common porphyria out of all porphyria is porphyria cutanea tara. And also this is exacerbated with alcohol consumption. Acute intermittent porphyria is also exacerbated by alcohol consumption, and causes include familial hepatitis C and virus infection, and also treatment is phlebotomy, and phlebotomy is the excision of specific part of veins, and then sun avoidance, antimalarials like hydroxychloroquine are treatment. So this is the figure, this is the flow chart of how heme synthesis occurs, right? So usually this is what we study in biochemistry, but let me tell you something about this very broadly. So there are two sites of synthesis, mitochondria and then cytoplasm. Succinyl coenzyme A and glycine then combine in the presence of ALA synthase enzyme, which is rate limiting step of the heme synthesis, to form aminolevulinic acid, right? So ALA is aminolevulinic acid, and these things are inhibited by glucose or hemine and sideroblastic anemia, which is X-linked disease. So glucose and hemine is the treatment in this case, because ALA is already accumulating. So ALA accumulation should be prevented. Since this first step is prevented, inhibited, then ALA will not be formed, thus the accumulation does not occur, right? So this ALA, in the usual case, what happens is ALA dehydrogenase enzyme will convert this into porphobilinogen, and then the lead poisoning affects in here, and also in the last step where ferrosolitase is used. So porphobilinogen, in the presence of porphobilinogen deaminase enzyme, will form hydroxymethylbilane, which is an intermediate product. So hydroxymethylbilane is an intermediate product that will spontaneously go to the uroporphyrinogen. Since if the porphobilinogen deaminase enzyme is inhibited, that is affected, then what happens is acute intermittent porphyria happens like this. This is an autosomal dominant mutation, right? And that will cause acute intermittent porphyria. Then in a spontaneous reaction, hydroxymethylbilane will convert into uroporphyrinogen 3. And this uroporphyrinogen 3, in the presence of uroporphyrinogen decarboxylase, will get converted into coproporphyrinogen 3. So if this enzyme is inhibited, there is porphyria cutanea tara symptoms, right? So this is the most common type of porphyria, as we talked earlier. These are the symptoms. So blisters like photosensitivity is occurring. So this coproporphyrin again in the presence of some transport proteins will cross this mitochondrial membrane and form protoporphyrin. This protoporphyrin, when gets combined with iron in the presence of ferrosolitase enzyme, it will form heme. That is how heme synthesis actually occurs. And in the last step, this ferrosolitase enzyme is affected by lead. So lead poisoning usually occurs, the impairment in heme synthesis. This is the rough idea. We'll go into the details in our biochemistry sessions. So basically, what is iron poisoning? Let's go into the iron poisoning. Iron poisoning occurs via free radical formation and membrane lipid peroxidation, which will lead to cell death. This is how iron poisoning occurs. So in the findings of iron poisoning, there are acute and chronic findings. So acute findings: in the acute iron poisoning, what actually happens is increased mortality rate associated with accidental ingestion by children. Like adult iron tablets may look like candies. That is why, adult iron tablets may look like candy, so the children may tend to eat those. That will lead to the increase in mortality rate. That is the finding. The symptoms or signs are abdominal pain, vomiting, and GI bleeding. These are very like gastric upset occurs due to iron overload. Gastric upset is the main signs and symptoms, right? And radio-opaque peel seen on X-ray may progress to anion gap metabolic acidosis and multi-organ failure. This metabolic acidosis and alkalosis, we will talk about this later, right? This is very important, like high anion gap metabolic acidosis and then normal anion gap metabolic acidosis. These are very important things to be understood, and it will lead to scarring with GI obstruction. These are the signs and symptoms of the acute iron poisoning. The treatment is chelation, that is deferoxamine or deferasirox is used, and also gastric lavage is done. Gastric lavage is done. And in the chronic cases, what actually happens is they are seen in patients with primary or hereditary and also secondary, example chronic blood transfusion for thalassemia or sickle cell disease due to hemochromatosis. This is the presenting symptom. Presenting symptom in chronic iron poisoning is hemochromatosis. The signs and symptoms include arthropathy, cirrhosis, because cirrhosis, iron is metabolized in liver, and then cardiomyopathy, diabetes mellitus, and skin pigmentation like bronze diabetes. This is very high yield. So bronze colored skin is due to iron overload. You have to remember that. Not only iron overload, there are many other reasons that can occur or manifest as bronze colored skin, but this bronze colored skin usually occurs in iron poisoning. And the treatment is again chelation and regular therapeutic phlebotomy unless contraindicated, example in anemia, is done, and that is how iron poisoning is finished. So coagulation disorders, these are the collective disorders in which coagulations or coagulators are in abnormal conditions. So there are different kind of tests that we have to do to find out if there is any coagulation disorders like hemophilia A, B, C, or vitamin K deficiency. We have to think about that, right? So PT is prothrombin time, and it tests function of common and extrinsic pathways, right? Extrinsic pathways, like in extrinsic pathway of coagulation, the factors I, that is 1, 2, 5, 7, and 10 are used. 1, 2, 5, 7, and 10 are used in extrinsic pathway of coagulation. So defect is that there is increased prothrombin time, that is play tennis outside. That is why extrinsic pathway is affected. So P is prothrombin, T is time. So play tennis outside because extrinsic pathway. And in PTT, we have to play table tennis inside because it is an indoor game, right? So that is how we remember. In PTT, there is play table tennis inside. You have to remember like that. And INR is actually international normalized ratio. This is the ratio of patient prothrombin time to the control prothrombin time. So 1 is normal. If this ratio is 1, then it is a normal case. But if it is greater than 1, like greater than 1, like 1.5 in HELP syndrome, like if that happens, then most common test used to follow patients on warfarin, which prolongs INR. Warfarin is anticoagulant, and also heparin, low molecular weight heparin. We have to do PT monitoring or INR monitoring to titrate the dose for any presenting symptoms, right? So basically PT is all about this. So we have to consider INR for PT tests, and in PTT we test functions of both common and intrinsic pathway. Usually intrinsic pathway that includes all factors except 7 and 13, except 7 and 13, right? All factors are included in this except 7 and 13. I'm so sorry. So I sometimes stutter, but that's not intentional. Okay. TT. So TT measures the rate of conversion of fibrinogen to fibrin, that is prolonged by anticoagulants, hypofibrinogenemia, and also disseminated intravascular coagulopathy and liver disease, because liver is where these coagulation factors are formed. So liver disease obviously affects these all factors, right? So coagulation disorders can be due to clotting factor deficiencies or acute factor inhibitors, most commonly against factor 8. So they are diagnosed with a mixing study in which normal plasma is added to patient's plasma. Clotting factor deficiencies should correct the PT or PTT returns to within the appropriate normal range, whereas factor inhibitors will not correct. That is what happens. Factors inhibitors will not correct, but deficiencies can be corrected. So the disorders in coagulation are usually hemophilia A, B, C, as I have said earlier, and also vitamin K deficiency. What happens in hemophilia A, B, C is this is genetic disease. In A, there is a deficiency of factor 8, like hemophilia 8, right? Okay, you can remember like that, hemophilia 8. A for 8, E for 8. They pronounce like same, right? So intrinsic pathway coagulation defect. Hemophilia A, B, and C, all three of them are intrinsic pathway coagulation defect, and B is deficiency of factor 9, that is X-linked recessive. Both are X-linked recessive. And hemophilia C is deficiency of factor 11, which is autosomal recessive. All of these three are recessives, but the both 1 and 2, A and B, is X-linked, and C is autosomal. So hemorrhage in hemophilia causes hemarthrosis, that is bleeding into joint, or in joints there are accumulation of blood. So bleeding into joints, example in knee, here you can see that is hemarthrosis. Hemarthrosis is a common presenting symptom of hemorrhage in hemophilia if this is severe, and also easy breathing and bleeding after trauma or surgery, example dental procedures occur in hemophilia cases. The treatment are desmopressin, factor 8 concentrate, emicizumab, which is a recombinant drug, and also factor 9 concentrate B, and then factor 11 concentrate in C. That is how we treat. In factor A, like hemophilia A, we have to treat with desmopressin, factor 8 concentrate, emicizumab, and in B, hemophilia B, we have to treat the disease with factor 9 concentrate, and in C, factor 11 concentrate, right? In vitamin K deficiency, this is the general coagulation defect. PTT is raised in both of these cases, and PT is not raised, or it can be normal in hemophilia cases, but it is raised in vitamin K deficiency. So vitamin K is actually a maturating factor, right? So bleeding time is usually normal, and then decreased activity of factors 2. This is a kind of activating factor. So factors for factor 2, factor 7, 9, 10, protein C and protein S. But if there is vitamin K deficiency, then that is what it occurs, general coagulation defect. So let's go to the platelet disorders. There are a lot of platelet disorders, and all platelet disorders have increased bleeding time, mucous membrane bleeding, and micro hemorrhages like petechiae and epistaxis, which is nose bleeding. And also platelet count is usually low, but may be normal in qualitative disorders. Qualitative disorders are actually the structural disorders of platelets, like how they form, how they act, like that can happen in qualitative disorders. And in those disorders, platelet count can be normal, right? So the disorders include Bernard-Soulier syndrome, Glanzmann thrombasthenia, immune thrombocytopenia, and uremic platelet dysfunction. So let's go. In Bernard-Soulier syndrome, what happens is PC is either normal or decreased, and then PC is platelet count obviously, and then BT, which is bleeding time, is increased. Bleeding time is increased in all these four diseases. And Bernard-Soulier syndrome is actually autosomal recessive defect in addition, where GPIB is decreased. So decreased platelet to bone Willebrand factor addition occurs. GPIB is a receptor, right? So the defect is in GPIB receptor in Bernard-Soulier syndrome. GPIB and GP2B3A, these all are receptors in platelet aggregation. We will talk about this in later in physiology, where we do coagulation. So you have to subscribe. I'm so sorry, but you have to subscribe. And decreased platelet to bone Willebrand factor. There is also a disease called bone Willebrand factor disease. We will talk about this in this session. And also the lab's findings is that there is decreased platelet aggregation, which is big platelets can occur. In Bernard-Soulier syndrome, there are big platelets. B for Bernard-Soulier, B for big platelets. And in Glanzmann thrombasthenia, BT is increased, obviously. And this is autosomal recessive defect in aggregation. This is defect in addition, but this is defect in aggregation. So there is a defect in another receptor, that is GP2B3A receptors. And also that is decrease in integrin alpha 3 beta 3. That will lead to platelet aggregation defective and defective platelet product formation. What actually happens, let me tell you this. I thought I would be telling this in a physiology session, but I want to tell it right now. What actually happens is if there is a bleeding disorder from this vessel, right? So one platelet have to bind with this endothelial cell right here. And this endothelial cell, like subendothelial region, there is bone Willebrand factor released, right? So this factor should be bound to this platelet, and the receptor used is GP1B, right? So GP1B receptor is in Bernard-Soulier syndrome, but one platelet cannot block the insult, right? So there should be other platelets that should come, and these platelets now combine to each other to form an aggregate. That aggregate forms in a combination. This combination occurs with a receptor called GP2B3A receptor. That is what it is. So autosomal recessive defect in addition is Bernard-Soulier syndrome, but in aggregation is Glanzmann thrombasthenia. So in labs, blood smear shows no platelet clumping, right? So obviously because there is no receptors. And in immunothrombocytopenia, what actually happens is destruction of platelets in spleen, most commonly due to, again, this is a condition where GP2B3A receptors have autoantibodies formed. So that will lead to splenic macrophages, phagocytose. Platelets, this may be idiopathic or secondary to autoimmune disorders like SLE, or viral illnesses like HIV, HCV, malignancy like CLL, that is chronic lymphoid leukemia, and again drug reactions. You have to know HIV is human immunodeficiency virus, and then HCV is hepatitis C virus. SLE is systematic lupus erythematosus. And in labs, what we see is increased megakaryocytes and bone marrow biopsy, and decreased platelet count. What are megakaryocytes? Megakaryocytes are actually immature platelets, and then these are the precursor of platelets, mature platelets, you can say like that. And the treatment is glucocorticoids, IVIG, rituximab, TPO receptor and agonist, example eltrombopag, and also romiplastim. And splenectomy can be done for refractory ITP, that is immune-mediated thrombocytopenia. The other symptom, other disorder of platelet is uremic platelet dysfunction, where bleeding time is again increased, and in patients with renal failure, uremic toxins accumulate and interfere with platelet addition and aggregation. This is the basic pathophysiology. So another here is thrombotic microangiopathies. We have to remember this. There are two types usually: thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. HUS actually occurs in Escherichia coli disease, which is also cigatoxin producing disease. So let's tap into what the differences are. So, thrombotic microangiopathies, these are the disorders overlap significantly in symptomatology, and they may resemble DIC, which is disseminated intravascular coagulopathy, but do not exhibit lab findings of consumptive coagulopathy. Example, increased PT, increased PTT, decreased fibrinogenase. Etiology does not involve widespread clotting factor activation. So let's go to the differences, right? So in differences, epidemiology, TTP, which is thrombotic thrombocytopenic purpura, is typically affecting females, and hemolytic uremic syndrome is typically affecting children. The pathophysiology is that inhibition or deficiency of ADAMTS13. This is what you have to remember. In TTP, there is a deficiency or inhibition of ADAMTS13, but in ITP, as we have talked earlier, there are autoantibodies to GP2B3A receptors. This is the main difference in a pathophysiological basis. So ADAMTS 13 is actually bone-wildeband factor metalloprotease, and this will lead to decrease in degradation of BWF multimers, and that will lead to increase in large BWF multimers, so increase in platelet addition and aggregation, microthrombi formation. Microthrombi forms, and then it will obstruct the lumen of blood vessels, right? So this is a thrombotic microangiopathy, that is small blood vessels are affecting. And then the pathophysiology is that predominantly caused by cigatoxin producing, as I have talked earlier, it is Escherichia coli, that is STC infections like serotype O157 and S7. Not all serotypes of Escherichia coli, but O157S7 strain or serotype is very harmful, which will cause profound endothelial dysfunction. So the presentation of both of these symptoms is that triad of thrombocytopenia, that is decreased platelets, and microangiopathic hemolytic anemia, MHA or MAHA, we remember that as MAHA, which is MAHA, and then MAHA usually presents as decreased in hemoglobin, and cystocytes presence, and also LDH is increased due to increased cell turnover. And acute kidney injury. Acute kidney injury is like it is represented by increase in serum creatinine. So what is the triad? The triad of thrombotic microangiopathies is thrombocytopenia, microangiopathic hemolytic anemia, and acute kidney injury. You have to remember this. And differentiating symptoms is triad plus fever plus neurologic symptoms are there. But in triad plus bloody diarrhea because cigatoxin producing Escherichia coli usually causes bloody diarrhea in gastric system. And also the labs, so normal PT and PTT helps distinguish TTP and HUS. Coagulation pathway is not activated from DIC. Coagulation pathway is activated. So in DIC cases, there are abnormal PT and PTT, but in TTP and HUS, there is normal PT and PTT. So basically, that is how we distinguish it in TTP and HUS to DIC, right? So the treatment is plasma exchange and glucocorticoids, also rituximab in TTP, but supportive care in HUS, obviously. You can use antibiotics for this bacteria if there are GI symptoms also. So mixed platelet and coagulation disorders, right? So the difference between platelet and coagulation disorder is that there are the affecting factors in PT, that is prothrombin time, and partial thromboplastin time, which is PTT. There is affecting factors in coagulation disorders, but in platelet disorders, the coagulation pathway is not affected. So there can be conditions where there is both platelet and coagulation disorders. The conditions like bone-Willebrand disease, as we had talked, and also disseminated intravascular coagulation disease. We'll also talk about hereditary thrombophilias in a few moments. So in bone-Willebrand disease, what actually happens is the bleeding time increases, and PC, platelet count, can be normal, and also prothrombin time can be normal, and PTT either increases or is normal. So what is actually PWD? It is an intrinsic pathway coagulation defect. Intrinsic pathway where there is decrease in quantity and function of BWF that will lead to increase in partial thromboplastin time. BWF carries / protects factor 8. Defect in platelet block formation occurs because there is decrease in BWF. What actually happens is defect in platelet to BWF addition, as I have figured it out earlier, and that will lead to defect in platelet to BWF addition, right? So the insult is not plugged normally, so there is a bleeding disorder. So the most of these cases are autosomal dominant, mild but most common inherited bleeding disorders are these, and they commonly present with menorrhagia or epistaxis. Menorrhagia and epistaxis, because this is bleeding disorder. Menorrhagia is actually heavy menstrual bleeding, and epistaxis is nosebleed. So treatment is BWF concentrates desmopressin, which releases BWF from stored in endothelium. That is the mechanism of action of desmopressin. We'll talk about that in pharmacology. So in disseminated intravascular coagulation, what actually occurs is platelet count is decreased and bleeding time is increased. Then again, prothrombin time is increased, partial thromboplastin time is also increased. So only platelet count decreases and all three other markers are increased. So what actually happens is widespread clotting factor activation occurs, and that will lead to thromboembolic state with excessive clotting factor consumption, right? So there is increased thrombosis. Widespread clotting factor activation, that will lead to thromboembolic state with excessive clotting factor consumption. Since these clotting factors are consumed excessively, they will form microthrombi or thrombosis. And then also increase in hemorrhages, example, blood oozing from puncture sites occur, may be acute or life-threatening, or can be chronic if clotting factor production can compensate for consumption, right? So the causes are heat stroke. Stop making new thrombi. We have to remember like this. Stop making new thrombi. As for heat stroke, as for snake bites, as for sepsis, which is gram-negative bacteria causing sepsis, T is trauma, then O is obstetric complications, then P is acute pancreatitis, then M is malignancy, N is nephrotic syndrome, and T is transfusion. So stop making new thrombi. So in disseminated intravascular coagulation, these microthrombi are the problem, so you have to stop making them. So stop making new thrombi are the causes for DIC. You have to remember this mnemonics at any cost. The labs show cystocytes, increased fibrin degradation, products like D-dimers, and decrease in fibrinogen, decrease in factors B and factors 8. It's 11:11 time in where I am residing right now, so you can make a wish if you are with me. Yeah, so the wish can be you have to crack USMLE Step 1 with 260 plus scores, and also Step 2, and also you have to get residency what you want. So there are hereditary thrombophilias, but off note, I don't believe in wishes. We have to work for what you want. So in hereditary thrombophilias, what actually occurs is that autosomal dominant disorders resulting in hypercoagulable state, and that will lead to increase in tendency to develop thrombosis, right? So the diseases in hereditary thrombophilias, there should be increase in thrombocytes. So antithrombin deficiency, it has no direct effect on PT, PTT or thrombin time, but diminishes the increase in PTT following standard heparin dosing, and it can also be acquired, as in renal failure or nephrotic syndrome, that will lead to antithrombin loss in urine, and thus decrease in inhibition factors of factor 2A and 10A that can cause antithrombin deficiency. And factor B Leiden is another disease in which there is production of mutant factor B, that is guanine is replaced by adenine by a DNA point mutation, and that will lead to ARG506GLN mutation near the cleavage site. What is the mutation name in factor B Leiden? That is arginine 506 guanine. That is how we remember. That it is an example of DNA point mutation, and that is resistant to degradation by activated protein C. So this protein factor here, this coagulation factor right here, is resistant to degradation. So the complications include DVT, which is deep venous thrombosis, cerebral vein thrombosis, and also recurrent pregnancy loss, right? So another disease here is protein C or S deficiency that will lead to decrease in ability to inactivate factors 8A and 5A. So it will there is increase of risk of warfarin induced skin necrosis in these cases, in protein C and protein S cases. deficiency cases, right? So together protein C cancels and protein S stops. That is what occurs in coagulation. The coagulation is cancelled, C for cancelled by protein C, and S for stopped by protein S. So protein C and protein S deficiency has an inability to inactivate factors 5A and 8A. The other disease in hereditary thrombophilia is prothrombin G2021OA mutation. Point mutation in 3' untranslated region that will lead to increase in production of prothrombin, that will lead to increase in plasma levels and venous clots. These are the diseases we have to remember in hereditary thrombophilias. And out of these, we have to remember antithrombin deficiency and protein C and protein S deficiency is must. So there are blood transfusion therapies, not whole blood is used every time for every diseases where there is blood required. There are the fractionated amounts of blood that can be used in different situations. So basically there are components. The packed RBCs are usually used in what cases? Dosage effect. If we infuse packed RBCs, there will be increased hemoglobin, obviously, and also oxygen binding carrying capacity, and there will be increased hemoglobin of 1 gram per deciliter per unit of blood. 1 unit of blood will lead to increase in 1 gram per deciliter of hemoglobin, and also there is increase in hematocrit, that is 3% per unit. So remember these factors, right? So clinical use is acute blood loss and severe anemia. We can use packed cell RBCs. And then in platelets, the dosage effect is the platelet count greater than 30,000 microliter per unit of blood. That is increase in 5,000 per mm³ per unit. So it will be extensively used in dengue fever cases, right? So it stops significant bleeding, and thrombocytopenia, qualitative platelet defects can occur. Like these clinical uses are these of platelet transfusion. And fresh frozen plasma or prothrombin complex concentrate is used in cirrhosis cases, immediate anticoagulation reversal, where in conditions where there is immediate anticoagulation reversal is required, we use fresh frozen plasma. So what is the dosage effect? The dosage effect is that it increases coagulation factor levels. FFP, that is frozen plasma, contains all coagulation factors and plasma proteins. And PCC generally, PCC is prothrombin complex concentrate. It generally contains factors 2, 7, 9 and 10, as well as protein C and S. 2, 7, 9 and 10, this is intrinsic factor, and also protein C and S, as we have talked earlier. The cryoprecipitate is used where it is mainly composed of fibrinogen, right? And also factor 8, factor 13, BWF and fibronectin. These are used in coagulation factor deficiencies involving fibrinogen and factor 8. The albumin is used in post-paracentesis cases, therapeutic plasmapheresis cases, and then the clinical effects are that it will lead to increase in intravascular volume and oncotic pressure. So blood transfusion risks include infection transmission low. That is the one, if the transfused blood is already infected, then there is a case of infection. There is a risk of infection in a person in which the blood is transfused. And transfusion reactions can occur. Transfusion associated circulatory overload, that is TACO. Transfusion associated circulatory overload. This has a very wide spectrum of disease symptoms and severe enough. You have to remember this. So volume overload causes pulmonary edema and hypertension, and in long run it can also cause congestive heart failure. So in transfusion related acute lung injury, which is TRALI, you have to remember these two symptoms, right? TACO and TRALI are very much manifested clinical symptoms in blood transfusion. TRALI, which is transfusion related acute lung injury, it can cause hypoxia and inflammation, to non-cardiogenic pulmonary edema and hypertension. Then iron overload may lead to secondary hemochromatosis. Hypocalcemia, citrate is a calcium chelator, and hyperkalemia, RBCs may lies in whole blood units. In whole blood units, RBCs may lies, so that can cause hyperkalemia. There are different clinical symptoms of hyperkalemia, like arrhythmia in our heart. There are different symptoms. We have to consider each of these. So now we'll be tapping into WBC. WBC disorders is a very wide range of topic. So And also very much important findings are there in WBC pathology, mainly in Hodgkin's lymphoma and non-Hodgkin's lymphoma. You have to remember each of these factors, and then we will go to plasma cell dyscrasias like multiple myeloma, and then also leukemia. There are 4 types of leukemia on the basis of their lineages, and we will go to the myeloproliferative neoplasms, and that is when we will finish our pathology session. So be patient if you are still with me, because I am being patient even if I am talking non-stop. So well, let me have a gulp of water, please. Okay, thank you. Leukemia versus lymphoma. There is difference between leukemia and lymphoma. What is the actual difference? The actual difference is that leukemia, it is lymphoid or myeloid neoplasm with widespread involvement of bone marrow, whereas lymphoma is a discrete tumor mass arising from lymph nodes. These two terms are very often confused terms, right? So tumor cells are usually found in peripheral blood in the case of leukemia, and there is a variable clinical presentation in case of lymphoma. There is like increase in arising in atypical sites. Leukemic presentation can occur in lymphoma. So the lymphoma, there are types of lymphomas, that is Hodgkin lymphoma and non-Hodgkin lymphoma. These two differences are very important differences. If you had to remember only one topic out of like if you can remember only one topic in WBC literature, then you have to choose this one. This is that much important. So Hodgkin lymphoma, both may have constitutional B signs and symptoms like low-grade fever, night sweats, and weight loss. These are common in both of these, Hodgkin and non-Hodgkin. And localized. Hodgkin's lymphoma is localized, single group of nodes with contiguous spread is there. Stage is strongest predictor for prognosis. So stage of lymphoma is the strongest predictor for prognosis and also better prognosis. And it is characterized by the Reed-Sternberg cells. This is the characteristic, like signature feature of Hodgkin lymphoma, which is Reed-Sternberg cells. There is bimodal distribution, young adults and age greater than 55 years, and it is associated with Epstein-Barr virus. And in non-Hodgkin lymphoma, there are multiple lymph nodes involved. Extranodal involvement is very common, and there is non-contiguous spread, and also worse prognosis than Hodgkin lymphoma. There is non-contiguous spread, but there is contiguous spread in Hodgkin's lymphoma, and majority involves B cells, rarely of T cell lineage. It can occur in children and adults. It may be associated with autoimmune diseases and viral infections like HIV, EBV, and STLV, human T cell lymphoma virus. Right? So let's go tap into details in Hodgkin lymphoma. Hodgkin lymphoma, as I have said earlier, Reed-Sternberg cells is very much characteristic feature. It is distinguished if tumors are in cells. You can see these cells in here, like wool's eye appearance. You can see there are wool eye appearance in here, right? Wool eyes, and also bilobe nucleus with the two halves as mirror images. You can see bilobe nucleus, and two halves of these bilobe nucleus is like mirror images in between, right? They are also called wool eyes, not to be confused ever again. And these are CD15 positive and 30 positive. They are of B cell origin. 2 wool eyes into 15 equals 30. So CD15 plus times 2, which is 2 wool eyes, and which is bilobe nucleus is Reed-Sternberg cells, in equals 30. CD15 plus positive and also CD13 plus positive. There are subtypes of this, which is nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. Nodular sclerosis is most common type, and mixed cellularity, there is eosinophilia as seen in immunocompromised patients. In lymphocyte rich, this is the best prognosis case. The rich have better bank accounts, obviously, so treatment is usual. Worst prognosis, because the poor have worst bank accounts, seen in immunocompromised patients. So lymphocyte rich has best prognosis, but lymphocyte depleted has worst prognosis because the poor have that is depletion. There's depletion in here, so the poor have worse prognosis, right? So let's go into the non-Hodgkin lymphoma. There are a lot of types of non-Hodgkin lymphoma. We will tap into each of them right here. First one is Burkitt lymphoma. So Burkitt lymphoma, this occurs in adolescents and young adults. Burkitt lymphoma more common is in kids. So KITT is KID right here. So Burkitt, this is more common in kids. Burkitt lymphoma is more common in kids. The translocation of MYC8 and heavy chain occurs in immunoglobulin 14 occurs. The characteristic appearance is starry sky appearance, that is sky burst appearance. Starry sky appearance, seeds of lymphocytes with interspersed tingible body macrophages are seen. It is associated with Epstein-Barr virus, and it also shows something called Warburg phenomena. We have talked about it in general principles. You can take a look in neoplasia section of that. So jaw lesion is usually seen in Africa, pelvis or abdomen in sporadic form. So we have to, there must be a figure right here, right? So yes, here you can see Burkitt lymphoma. See, starry sky appearance is there, right? And also there are tingible macrophages, tingible body macrophages present. This is starry sky appearance. And here is the jaw lesion you can see in Burkitt lymphoma. The epidemiology is of Africa. Another type is diffuse large B-cell lymphoma. It usually occurs in older adults, but 20% in children. Then mutations of BCL2 and BCL6 is there. Most common type of non-Hodgkin lymphoma in adults. You have to remember this. This is all most common diseases you have to remember. In all cases, not only in WBC disorders, but in RBC, platelet, plasma cell disorder, in all cases. So most common type of non-Hodgkin lymphoma in adults is diffuse large B-cell lymphoma. Remember this. The another type is follicular lymphoma. It occurs in adults. The translocation of heavy chain immunoglobulin 14 and BCL2 18 is done. This has an indolent course, which is very slow course, with painless waxing and waning lymphadenopathy. Waxing and waning is that, suppose this is a lymph node, there is lymphadenopathy and swelling of lymph nodes right here in one stage, then again the lymph nodes get small, then again the lymph nodes get large, which is waxing, and again the lymph nodes get small, which is waning. That is waxing and waning lymphadenopathy. BCL2 is normally inhibits apoptosis. So there is mantle cell lymphoma. You have to remember that already the name has man in it, so the predisposition is more in man, adult males greater than adult females. Translocation is of cyclin D1 and heavy chain immunoglobulin 14, CD5 positive is the case. This is a very aggressive case, and patients typically present with late stage disease. It has a very aggressive course, mantle cell lymphoma. And another one is marginal zone lymphoma, adults. Here you can see. These all are mature B cells, neoplasms of non-Hodgkin lymphoma. Okay, remember this. Mature B cells. Okay, these all are mature B cells. And marginal zone lymphoma, this occurs in adults. Translocation 11-18. It is associated with chronic inflammation. Example, Sjogren syndrome, which is autoimmune syndrome where there is like a decrease in sweat glands, and also chronic gastritis, malt lymphoma, and then may regress with H. pylori eradication. The other disease or lesion, neoplasm of mature B cells, here is primary central nervous system lymphoma, occurs in adults. They are associated with EBV, that is Epstein-Barr virus related, and also HIV and AIDS. This is considered an AIDS defining illness. And this has variable presentation, confusion, memory loss, seizures, CNS mass, often single ring enhancing lesion on MRI. Single ring enhancing lesion on MRI is seen, and let's see, this ring enhancing lesion in MRI is seen in the case of primary central nervous system lymphoma. Okay, so it needs to be distinguished from toxoplasmosis by a CSF analysis or other lab tests. Okay, we will do that. Let's go to the neoplasms of mature T cells, which The first one is adult T-cell lymphoma. Second one is cutaneous T-cell lymphoma. In adult T-cell lymphoma, obviously, then by name it says that the adults are most commonly affected. It is caused by STLV, human T-cell lymphoma virus, associated with IV drug use. The adults present with cutaneous lesions most common in Japan. So T-cell in Tokyo. Tokyo is the capital city of Japan. So T-cell in Tokyo. West Africa and the Caribbean, there are lytic bone lesions. This is very important. Lytic bone lesions and hypercalcemia present in adult T-cell lymphoma. In cutaneous T-cell lymphoma, it is also most common in adults. This has a heterogeneous group of T-cell neoplasm affecting skin, with or without blood, lymph nodes, or viscera. So most common subtype is mycosis fungoides. This is a very much asked question. Cutaneous T-cell lymphoma, there is subtype. The most common subtype is mycosis fungoides. This is very, very important. Note it down right here. So there are skin lesions in here, characterized by erythematous patches. You can see these erythematous patches favoring sun-protected areas that progress to plaques and eventually tumors. Here are tumors right here. There are plaques. There are rashes. Okay, patches. You can see. So let's go into the plasma cell dyscrasias. Plasma cell dyscrasias, group of disorders characterized by plasma cell dyscrasias. They actually present as M spike in our reaction in here, albumin, alpha 1, alpha 2, beta, gamma. There is a specific chart name for this. I forgot that. So electrophoresis, exactly. Yes, electrophoresis. There is M spike in electrophoresis during plasma cell dyscrasia. Let's see what is it. So these are the group of disorders characterized by proliferation of single plasma cell clone, typically overproducing a monoclonal immunoglobulin, also called paraprotein. That is what it is. So this is seen in older adults. Screening with serum protein electrophoresis, there it is. So electrophoresis, M spike represents overproduction of monoclonal immunoglobulin. This is the characteristic feature. Monoclonal immunoglobulin is excessively produced in plasma cell dyscrasia. So serum immunofixation and also serum free light chain assay is done. Urine protein electrophoresis and immunofixation required to confirm urinary involvement, as in urine dipstick only detects albumin. So diagnostic confirmation with bone marrow biopsy is also done. Diagnostic confirmation is done with bone marrow biopsy. So peripheral blood smear may show rouleau formation. RBCs stack like poker chips, or also like coins. You can remember like that. There are coins and you stack them like a tower. So that is what rouleau is. A Rolex formation, if you want to talk like that. Okay, that is the case of plasma cell dyscrasia. And also there are diseases for plasma cell dyscrasia: multiple myeloma, Waldenstrom macroglobulinemia. We have talked about this in our neoplasia chapter also, right? So we'll talk about that in detail in here. Monoclonal gammopathy of undetermined significance. Okay. So multiple myeloma is a very important disease. There is overproduction of IgG, most common, greater than IgA, then Ig light chain. So the clinical feature, this is a diagnostic, also clinical feature, CRAF criteria. C for hypercalcemia due to increase in cytokine secretion, interleukin 1, TNF, alpha, rank L protein by malignant plasma cells that lead to osteoclast activity. That is the reason, pathophysiology behind hypercalcemia. And R for renal insufficiency, and A for anemia, B for bone lytic lesions, that is Pons-Stout defect on X-ray is seen. Pons-Stout defect on X-ray is seen. You can see there are Pons-Stout defects in X-ray right here. And A, RBC rouleau formation, here you can see the figure of rouleau formation. So in X-ray, in skull, usually it is presented in skull, and also back pain and pathologic fractures can occur. The complications are infection risk, primary amyloidosis, and urinalysis may show immunoglobulin light chains. Bernstein's proteinuria is occur in myeloma kidney with negative urine dipstick, and bone marrow biopsy shows greater than 10% monoclonal plasma cells with clock-free chromatin C, and intracytoplasmic inclusions containing immunoglobulin, as You can see in the figure right here. Okay, this is clock cell chromatin, right? So another disease of plasma cell dyscrasia is Waldenstrom macroglobulinemia, where overproduction of IgM is done, macroglobulinemia, because IgM is the largest immunoglobulin. So clinical features include anemia, constitutional B signs and symptoms, lymphadenopathy, hepatosplenomegaly, hyperviscosity due to headache that lead to headache, bleeding, blurry vision, ataxia, and also peripheral neuropathy. Fundoscopy shows dilated, segmented, and tortuous retinal veins. Dilated, segmented, tortuous retinal veins, sausage-link appearance, bone marrow biopsy shows greater than 10% monoclonal B lymphocytes with plasma cell features. So monoclonal gammopathy of undetermined significance. There is overproduction of any immunoglobulin type, that is M spike less than 3 gram per deciliter, asymptomatic. There is no CRAF findings in monoclonal gammopathy. You have to remember this. There is no CRAF findings. Okay, 1 to 2% risk per year for progressing to multiple myeloma, right? Bone marrow biopsy shows less than 10% monoclonal plasma cells. So let's do this for now. We'll talk about this in our next sessions, and another topic also. We'll complete that. Thank you for staying with me until now. Thank you so much.